So hey everyone, welcome to Core Vet. So today in this particular video lecture, we'll be discussing about the aminoglycoside. So if we talk about the aminoglycoside, so generally the compound of the aminoglycoside are in the sulfated form. So why they are in the sulfated form? To make them what? More soluble. So obviously, if a drug is going to be a more soluble drug, then the tissue availability and the activity of that particular drug will be increasing. Okay, that's why they are sulfated. Okay, now if we talk about the aminoglycoside now, so we could have two sources. Okay, we could have two sources for that particular aminoglycoside. Okay, either the aminoglycoside could be get from what? The streptomyces, right? Or we could get the aminoglycoside from the micromonospora. Okay, so if we are getting the aminoglycoside from the streptomyces, right? So what suffix we are going to use? We are going to use suffix as mycin for that particular drug, right? And if the drug or if the aminoglycoside is going to be obtained from the micromonospora, then we are going to use the suffix mycin, right? For example of the drug that has been obtained from the streptomyces is your streptomycin, right? And if we are going to see the example for the drug that has been obtained from the micromonospora, so you can have the as an example as an gentamicin. Okay, so the gentamicin could be an example which has been obtained from the micromonospora, right? And if we talk about that, the aminoglycoside could not penetrate through the blood-brain barrier, but can penetrate the placental barrier. Okay, but can penetrate the placental barrier, that you should know. Okay, it could not penetrate the blood-brain barrier, but can penetrate the placental barrier. And if we talk about the affinity of the aminoglycoside towards which ribosomal complex part, I'll discuss that in the mode of action because it would be more pronounced there. Okay, so let's have the quick points for the aminoglycoside. I had discussed the first one, the second one. Yeah, one thing more, that they are not absorbed through the oral route, okay, as they are polycations, right? And they are excreted via the kidney, okay, and that too in the unchanged form. Means there is no changement has been made for the aminoglycoside for the purpose of the excretion. Okay, and exclusively this particular class of drug is used for the treatment of the gram-negative bacteria, right? If a patient has been suspected for the infection that has to be caused by the gram-negative bacteria, then you can prescribe the aminoglycoside class of drug. Okay, and this point I'll discuss in the mode of action that there itself. Okay, and this is a bactericidal class of drug. Okay, and more active at the alkaline pH, and the partial cross resistance has been obtained and observed in this particular class of drug that I had told you, that too in the general chemotherapy, and post antibiotic effect is also observed in the aminoglycoside, right? That too I had discussed, right? Majorly of the points we are going to discuss in the classes of the drug, major points have been already discussed in the general chemotherapy, because the general chemotherapy is a part from which the maximum of the MCQ could be covered, right? That's why the general chemotherapy is quite important, right? And the aminoglycoside class of drug is having what? The narrow margin of safety, and is showing what? The ototoxicity and the nephrotoxicity that we will discuss in the adverse effect regarding the aminoglycoside. Okay, so let's move towards the classification. So if we talk about the classification, so the classification of the aminoglycoside could be categorized into three parts. First one is the narrow spectrum, second is the broad spectrum, and third one is the extended spectrum. So if we talk about the narrow spectrum, so in the narrow spectrum, the very first drug is your streptomycin. Okay, that has been obtained from what? The Streptomyces griseus. I had told you, see the suffix, that's the mycin, mycin, right? And the mycin suffix has been from what? From the streptomycin, right? So that's why the streptomycin has been obtained from what? The Streptomyces griseus. And the streptomycin is active against the Mycobacterium tuberculosis. Okay, it is active towards what? Mycobacterium tuberculosis. And if we talk about the next drug, the very next drug is the dihydrostreptomycin, right? If we talk about the spectrum for that particular class of drug, which is the narrow spectrum aminoglycoside, so they are active against what? The aerobic gram-negative, staphylococcus, actinomycetes, and your leptospira, and your brucella. Okay, now moving towards the broad spectrum. So the very important drug in the broad spectrum is your neomycin, which is generally not given through the parenteral route. Okay. So moving towards the broad spectrum, so the very first drug that has been there in the broad spectrum, which is quite important, that's the neomycin. So what's the property of the neomycin is that it is generally not given through the parenteral route. Okay, it is not given through the parenteral route. And if we talk about from where this neomycin has been obtained, so the neomycin has been obtained from the Streptomyces freddi, right? Coming on to the next, which is the phragmicetin in the class of the broad, which is obtained from the Streptomyces laventale, right? Which is also known as what? Neomycin B. It could be there in the fillip, which is also known as the neomycin B. So it's the phragmicetin. Talking about the next, which is the kanamycin. So the kanamycin has been obtained from the Streptomyces kanamyceticus, right? Next is your paramomycin. Okay, so the paramomycin has been they're quite effective, which is effective against what? The tapeworm and the entamoeba too, right? So if we talk about the general spectrum of this particular broad spectrums, so they are active against what? The gram-negative and as the gram-positive. So they are also active against the E. coli, Klebsiella, Enterobacter, and the Salmonella. Now moving towards the extended spectrum, so it is quite important to know about the extended spectrum because gentamicin is a drug which is quite famously used in the veterinary, right? And it has been obtained from what? The Micromonospora purpurea. I had told you, see this suffix. It's the mycin, right? So the drugs that are there with the mycin, they are what? Obtained from the Micromonospora. Okay. Next is the tobramycin, which has been obtained from the Streptomyces tenebarius. Okay. Next is the amikacin, which is a semi-synthetic derivative of what? The kanamycin. Okay, it is a semi-synthetic derivative of kanamycin, and it is also very effective against the bacteria that are resistant towards the gentamicin. But this is a point that you should remember, right? Next is your cesomycin, which has been obtained from Micromonospora inuensis, right? Which is quite similar to the gentamicin in the activity aspect, right? Next is your nettlemycin, which is a semi-synthetic derivative of the cesomycin. If we talk about the general property regarding this particular extended spectrum class of drug, so if we talk about the extended spectrum class of drug, they are active against the gram-negative, gram-positive, as well as the Pseudomonas aeruginosa. Now, one property of the gentamicin is what? That gentamicin is 4 to 8 times more potent than what? Streptomycin. It is more potent than the streptomycin. How much time? 4 to 8 times. What does it mean? See, if the MIC, okay, if the minimum inhibitory concentration of gentamicin is 2 microgram, right, for the gentamicin, then it would be the equivalent efficacy or efficiency from streptomycin would be observed at what? At either 8 microgram or your 16 microgram. Means the efficacy or the efficiency for the streptomycin will be 4 to 8 times much more than the gentamicin. If the drug gentamicin is giving a response at 2 microgram, okay, then the same response or same potency would be shown at the 8 microgram or 16 microgram. This is the general example. It's not an accurate formulation. It is just to explain you the times variability, right? Okay, it's just a general example to have a more clearer concept regarding the MIC value. Okay, so the gentamicin is 4 to 8 times more potent than the streptomycin. But there is a thing that the streptomycin for the treatment of the tuberculosis, it is much more good as comparison to the gentamicin. Okay, if you are going to treat the tuberculosis case, then the streptomycin is much more efficacious than the gentamicin. Okay, so that's the point you should remember. Coming on to the next point, which is the amikacin and natalmycin, they are resistant towards the enzymes that are inhibiting the aminoglycoside. So the example of the enzyme could be your aminoglycosides acetyl transferase. Okay, so the aminoglycoside acetyl transferase lead to the inhibition of what? The aminoglycoside. But the amikacin and the natalmycin are what? They are resistant against the aminoglycoside inactivating enzyme. Right? So moving towards the next part, which is the mode of action. So remember, let's come to here. So consider this is the cell wall of the bacteria. Right? Cell wall of the bacteria. Right? And this is my aminoglycoside drug. Okay, so the first of all, what happened to have an penetration towards the inside of the cell? Okay, to enter the bacterial cell, there is an two requirement that an aminoglycoside ask कि मुझे अंदर जाने के लिए भैया दो requirement. Okay, so aminoglycoside is going to ask for the two requirements. First, there should be an active transport. I need a active transport. Means भैया मुझे ATP चाहिए अंदर जाने के लिए. ठीक है. And the next requirement for the aminoglycoside is in the periplasmic space. Okay, in the periplasmic space there should be oxygen. That first requirement was what? To penetrate the bacterial cell and to just reach the inside the bacterial cell. What I require, what aminoglycoside require, first of all it require an ATP, okay, for an active transport. Okay, next what aminoglycoside is asking for, it is asking that भैया मुझे पेरिप्लाज्मिक स्पेस में ऑक्सीजन भी चाहिए. So that's why the aminoglycoside is only active towards the aerobic organisms, not the anaerobic organism. So that's what the reason is, that aminoglycoside is functional only in the presence of oxygen in the periplasmic space. Okay, so these two requirements you should note that in the aminoglycoside mode of action, whenever you are going to write the aminoglycoside mode of action, you should write these particular 2 points. Must. These are must. Okay. So after the entrance of the aminoglycoside, what it will do? You all know about the central dogma, I guess, that from the DNA, you are going to lead to the formation of protein. Okay. So I'm just moving to the last process, which is the translation. Okay. So in translation, what happened? This is the mRNA. Okay, and mRNA reached the site where? At the ribosomal complex. Okay, so in the bacteria, it's the ribosomal complex has been formed by what? The 50S subunit and the 30S subunit. What aminoglycoside do? The aminoglycoside reach the what? The interface between the what? Ribosomal complex, right? And more specifically, if in examination someone is asking that where, at which subunit the aminoglycoside is acting, then you should answer that aminoglycoside is going to act at what? The 30S subunit. Okay, because in Phillips there are questions that at which particular subunit the aminoglycoside is going to act. So what you have to answer is, you have to answer at the 30S subunit, the aminoglycoside is going to bind and inhibiting the protein synthesis. Okay, that's what you have to answer, right? Particularly in answer, you can also write down that in theoretical answer, you can write that the aminoglycoside is also acting at the interface between the 50S and 30S subunit. But more specifically, you have to write down that it is acting at the 30S subunit. Okay, remember that the aminoglycoside is going to act at the 30S subunit. Okay, I hope this particular part is clear. Now, after acting at the 30S subunit and the interface between the 50 and the 30S subunit, what would aminoglycoside lead to? What consequences would be there? Because aminoglycoside won't be sitting alone, right? कि भैया तुम लोग कर लो नहीं. The aminoglycoside will lead to what? It will lead to what? Misreading of mRNA codon. Okay, so aminoglycoside, what it will lead to? It will lead to the misreading of the mRNA codons, right? And the second most thing what aminoglycoside will do, it will lead to the conversion of polysome ribosome to monosome, right? Means it will lead to the disintegration of the 50s and the 30s. Means the ribosomal complex will be going to be disintegrated, right? So what's the most important function of the aminoglycoside? First, it will going to attach at the 30th ribosomal subunit. Then what it will lead to? It will lead to the misreading of the mRNA codon. Okay, because in filler, the most two important points that are going to be asked by the examiner, it is the where it is acting at the 30th subunit, and what it is doing the misreading of the mRNA codon. Because the aminoglycoside is the only class of drug that you are going to study which is going to act by the misreading of the mRNA codon, right? So this is the mode of action, and I guess you don't have to study this again because I had explained all this particular thing right here in the diagram. Okay, if you want to study, you can just take a screenshot for this particular, right? So moving towards the pharmacokinetic property of the aminoglycoside. So it is poorly absorbed through the GIT. Okay, that's why we generally prefer to give the aminoglycoside through the parenteral route and mainly through the intramuscular route. Okay, we generally prefer to give aminoglycoside through the intramuscular route, and the absorption through this route is also rapid. Okay, and the peak concentration is obtained within 1 hour generally. Okay, now talking about its distribution, the distribution and the penetration of the tissues is minimum except at two sites, in the renal and in the case of the ear. Okay, in the kidney and in the ear, the penetration is good. Okay, but in the case of the distribution in the extracellular fluids of the other tissues, the penetration is minimum, but it have good penetration and good affinity towards the tissue of the kidneys and the perilymph and the endolymph of the internal ear. I'll discuss that in the adverse effect. Okay, and there is no penetration towards the blood-brain barrier, I had told you, and neither it will be coming into the milk, right? And it is eliminated in the unchanged forms. Okay, so the aminoglycoside will be going to excreted as it is, right? So there is an attainment of resistance by the bacteria. The bacteria won't be sitting like, oh, aminoglycoside come and damage me. No, with time the bacteria is going to produce what? Resistance towards the aminoglycoside. That's what the tendency of the bacteria is to develop, right? So how the resistance is going to be made against the aminoglycoside? So the very first mechanism is the inactivation of the aminoglycoside by the usage of the internal bacterial enzyme. Okay, so there could be three enzymes that are there. See, the first one is the aminoglycoside acetyltransferase that I had discussed that too in the upper part, where I had told you where the amikacin and natalmycin, right? Both are what? Resistance towards these particular enzyme, right? I had told you that too. Okay, now if we just talk about the next, okay, so if we talk about the next, there could be the mutation in the ribosomal structure. Means there may be the mutation in the 30th subunit such that the aminoglycoside isn't able to bind at the 30th subunit. If the aminoglycoside isn't going to bind at the 30th subunit, so obviously there won't be any misreading of mRNA, neither there would be the conversion of polysome into the monosome, right? So obviously the two mechanism is clear, either by the destruction of the aminoglycoside by the usage of the enzymes, right? So the next resistance mechanism could be obtained by what? The next resistant mechanism could be obtained by the mutation in the ribosomal structure, right? And the last your resistance mechanism could be there through the interference at the active transport. Okay, we all know the aminoglycoside penetrates through the active transport. So if there won't be any active transport for the aminoglycoside, obviously it won't be going to enter the bacterial cell, and no further consequences would be there to the bacterial cell, right? So this was about the resistance mechanism. Now talking about the clinical usage. Okay, so if we talk about the clinical usage, it is used in the treatment of the local and the systemic infections that are generally caused by, majorly we prefer for the aminoglycoside for the gram-negative bacteria, but obviously there are broad spectrum and extended spectrum, that too for the gram-negative as well as for the gram-positive, right? And they are more susceptible for the aerobic bacteria that I had told you. Why? Because the aminoglycoside requires the oxygen in the periplasmic space, right? If we talk about the streptomycin, okay, they are able to treat what? The staph infection, strepto infection. Okay, this is because the staph and strepto are common commensal for the mastitis, right? And streptomycin is also used for the treatment of the TB, right? It is used in the treatment of the TB, right? I had told you that particular. Okay, and next is your what? The infection by the Pasteurella, right? Through the E. coli, through Leptospira, and through the Vibrio. Okay, we are talking about the gentamicin. So gentamicin is generally given parenterally. Okay, and obviously it is kind of a drug of choice for the gram-negative septicemia. Okay, septicemia that will lead to the UTI. It is also used in the treatment of the GIT infection as well as in the respiratory tract infection. Okay, and obviously it is also used in the treatment of the eye and the ear infection, but the condition that is there with the ear infection, that in the ear infection, the ear tympanic membrane, if you are going to treat a particular case of the ear infection, so the tympanic membrane should be intact, right? The tympanic membrane should be always be intact when you are going to treat any infection of the ear, right? Now coming on about to the discussing about the pharmaceutin. So if we discuss about the pharmaceutin, so it is really used for the treatment of the systemic infection, okay, due to its property of the ototoxicity and the nephrotoxicity. Okay, it is generally used for the treatment of the enteritis, right, and otitis externa in the cases of the dog. Okay, topically application is made, right? If we talk about the natalmycin, so the resistant to the aminoglycoside inactivating enzyme is there. Okay, they are resistant towards the aminoglycoside inactivating enzyme that I had told you. Okay, so thus they could be used against the strain that are resistant towards the gentamicin. Now if we talk about the toxicity that has been shown by the aminoglycoside, okay, so there are three main toxicity that we observe in the aminoglycoside. The very first one is your ototoxicity, right? The second one is your nephrotoxicity, and third one is your neuromuscular blockade, right? These are the three main toxicity that we observe in the cases of the aminoglycoside. Why? Because see, in the above two cases, the main portion of the infection is what? It's your kidney and ear, right? So if we talk about your kidney and ear, so in your ear, in the endolymph and perilymph, they are the major site for the accumulation of the aminoglycoside. Okay, so in your internal ear, we all know there are two apparatus, the vestibular and cochlear. Okay, so these two particular apparatus that are there in your internal ears, so what happened? There is what? There is phosphatidyl inositol there. Okay, so in your ear, okay, so the major accumulation site is what? Endolymph and the perilymph, right? Where in the vestibular and the cochlear apparatus of your internal ears, there is a presence of a compound known as the phosphatidyl inositol, and the aminoglycoside have an affinity towards your phosphatidyl inositol. So due to the presence of phosphatidyl inositol in your majorly in the kidney and the ear, It's the presence in a higher amount, higher concentration. That's why the phosphatidyl inositol is also present in the renal tubules, right? That's why there is an what? Accumulation of the aminoglycoside. Because if there is going to be an accumulation of aminoglycoside due to the presence of the phosphatidyl inositol in the internal ear, what will it lead to? It will lead to what? The damage to the eighth cranial nerve. Okay, so obviously it will lead to the condition of ototoxicity. Means the patient won't be able to hear. Okay, so the sensation of the hearing would be lost. So generally what we see now, that in the patients that are going to be treated by the, in the case of the tuberculosis, we generally prefer what? We are going to prefer streptomycin from the your aminoglycoside, right? And streptomycin is an aminoglycoside. Obviously it will be going to deposit in your ear and kidney. Okay, when it will be going to deposit in your ear, obviously it will lead to the ototoxicity. So due to the ototoxicity that has been shown due to the presence of the streptomycin, as it has affinity towards the phosphatidyl inositol, it will lead to the loss of the sensation of hearing. That's why we observe what? The maximum, because the duration of the course of the tuberculosis is quite big, right? It is quite large, the duration of the course, right? Because the treatment of the tuberculosis is not for the shorter duration, it takes a long duration to treat the tuberculosis, right? So due to longer exposure of the body towards the streptomycin or the class of the drug, which is aminoglycoside, it will lead to the slowly deposition of the aminoglycoside in the internal ear apparatus, right? Due to the deposition of the aminoglycoside in the internal ear, it will lead to the damage to the eighth cranial nerve. Okay, which is responsible for what? Which is responsible for your hearing sensation, right? And if the hearing sensation would be lost, it will lead to what? It will lead to the ototoxicity, right? Similarly, in your kidney also there is phosphatidyl inositol. I'll discuss it later, right? I had discussed the mechanism of accumulation, right? So majorly it is accumulated in the perilymph and the endolymph, and where? In the internal ear, in the vestibular and the cochlear apparatus, as it contain what? The phosphatidyl inositol, for which the aminoglycoside has the affinity that I had told you, and this lead to the accumulation of the aminoglycoside in their particular regions. Okay, so I had told you that in the TB patient. Okay, the case of the TB patient I had explained you there. Okay, if we talk about the cats now, the cats are more susceptible towards the aminoglycoside toxicity as compared to dogs. Okay, note this point. Okay, now there is an MCQ site over here. Okay, there is an MCQ site over here. See, if the examiner is asking you which is the most toxic, which is the most ototoxic aminoglycoside, okay, then you are going to ask the neomycin. Then you are going to answer the neomycin. Okay, but if the examiner is asking you region wise, okay, if the examiner is asking you region wise, that where the vestibular and then the cochlear, okay, so in the vestibular the streptomycin is toxic than the gentamicin, and in the cochlear toxicity the neomycin is the most ototoxic, and then the kanamycin and the amikacin. Okay, if there are four options now, then you are going to take about the ototoxicity due to the aminoglycoside, you are going to answer what? Neomycin. Okay, चारों ऑप्शन में अगर neomycin दिख रहा है, then the answer is the neomycin for that particular toxicity. Okay, if the examiner is asking you about the ototoxicity and no region has been specified, then you are going to answer the neomycin. Okay, from the aminoglycosides, right? Moving towards the next toxicity, which is the neuromuscular blockade, which is showing a Curare-like action, right? Why? Because the aminoglycoside will be leading to inhibition of what? It will inhibit the fusion of the synaptic vesicle, means the acetylcholine or any other neurotransmitter won't be able to just be there in the synaptic space, right? So there won't be any transmission. Okay, it will lead to the chelation of the calcium ion. If there won't be any calcium ion, there won't be any transmission. Okay, and it also decrease the sensitivity of the motor end plates for acetylcholine. Okay, and if we see the sequential toxicity, then the kanamycin is more and then the amikacin, then the gentamicin, which is equivalent to the tobramycin. And the most toxic effect which is showing, it is your neomycin and the streptomycin. Okay, if it is more than kanamycin also, okay, means the neomycin and streptomycin more than the kanamycin, then your amikacin, then your gentamicin, which have equivalent toxicity than that of the tobramycin, right? And these shouldn't be given to the person which is affected from the myasthenia gravis. Why? Because in the myasthenia gravis itself, they have what? They have weakened muscle. They have already weakened muscle, and you are just giving or prescribing a drug which is already showing a neuromuscular blockade like action. Okay, so they shouldn't be prescribed to a person or the patient with the myasthenia gravis, right? And they can be antagonized by the usage of the IV infusion of the calcium borogluconate, because we do need a calcium supplement as there is chelation of the calcium, right? Or either you can use what? Neostigmine or physostigmine. What are they? They are cholinergic drug, right? Because they are going to what? They are going to inhibit acetylcholine esterase, which will lead to the excess of the acetylcholine in the synaptic space, right? That's what the use of the neostigmine and physostigmine is, that you had studies in the cholinergic transmission, right? Now moving towards the nephrotoxicity. So what happened in the basolateral membrane? This is the basolateral membrane, suppose, of what? Of PCT, right? Proximal tubule, right? So in the basolateral membrane of the PCT, there is an excess of what? Phosphatidyl inositol, that I had told you, that in the ear and the kidney, both have the higher concentration of phosphatidyl inositol, and the aminoglycoside have a tendency to attract or to just be there and to just love the phosphatidyl inositol, okay, because they have the affinity towards the phosphatidyl inositol that lead to the accumulation of the aminoglycoside at these two particular sites, which is the internal ear and your basolateral membrane of the PCT, right? As the aminoglycoside is going to just attach at this particular region of the kidney, what would it lead to? It will lead to the lower in the GFR. So the nitrogen retention rate would be there. Okay, there will be higher nitrogen retention as due to the nephrotoxic action, right? Higher blood urea nitrogen would be there, right? And what happened? What would it lead to? It will lead to what? Accumulation of aminoglycoside. Obviously, if there would be the accumulation of the aminoglycoside in the blood circulation also, so the blood will also go to the ear too, right? Blood will reach ear too. It will lead to the potentiation in the ototoxicity. Okay, if there would be nephrotoxicity, obviously the patient is going to have an ototoxicity, because if the kidney isn't excreting that particular, because I had told you the major route of excretion of the aminoglycoside is what? It's the kidney only. Okay, if the kidney is unable to just excrete out the aminoglycoside, obviously the concentration of the aminoglycoside in the blood circulation would be more. Okay, so if the blood circulation have a higher concentration of the aminoglycoside, obviously the ear also need the blood, right? So the ear will receive what? A blood circulation which is rich in the aminoglycoside. It will lead to the further absorption or the accumulation of the aminoglycoside at the internal ear side, which will lead to the potentiation in the what? The ototoxicity. That's what I had written over here. Okay. Now the kidney can be recovered by the discontinuation of the aminoglycoside. Means the action of the nephrotoxicity could be recovered if there is a discontinuation of the aminoglycoside drug, right? If we talk about the nephrotoxicity sequential, right? So the neomycin is the more toxic, then the gentamicin, which is equivalent to the amikacin, and then the least toxic is the tobramycin, right? Now one thing is more, that the chlorhexidine, the polymyxin B, furosemide, because polymyxin B is also a nephrotoxic drug, right? Polymyxin B is also nephrotoxic. We will discuss it later. And the salicylate plus the mannitol are also ototoxic. Okay, hence they shouldn't be given along with the aminoglycoside, because it will lead to the aggravation in the condition, right? That's why these particular drugs that I had mentioned over here, they shouldn't be prescribed along with the aminoglycoside, right? And if we talk about the aminoglycoside, it should also not be given with the halothane, which is an inhalational anesthetic that you had discussed or that you had learned in the CNS, right? In the pharmacology, CNS pharmacology, right? You must have studied about the inhalational anesthetic where you must came with the name halothane, right? Now talking about the next toxicity, which is the hypersensitivity, which is quite common, which will lead to the contact dermatitis, and allergic reaction are more common with the streptomycin. Okay, and there could be a CNS depression, convulsion, and respiratory failure, and decrease in the blood pressure on the rapid IV infusion of the aminoglycoside, right? And aminoglycoside obviously shouldn't be given to the guiding and the working dog, because the purpose of the guiding dog is to guide, and if the dog isn't able to hear, right, because the aminoglycoside lead to the ototoxicity, if the particular guiding dog or the working dog isn't able to just guide you, then what's the purpose of the guiding dog is, right? So that's why aminoglycoside shouldn't be prescribed to the guiding dog, because obviously the ototoxic condition could be produced, and shouldn't be given to the pregnant animal too, because they can cross the placental barrier, right? Now moving to the next, which is the drug interaction. The drug interaction could be drawn from the text that you had studied earlier only. Okay, you can just write it by yourself also. Okay, what that it shouldn't be given with the anesthetic. Obviously, it will, as it will lead to what? The aminoglycoside is doing what? Neuromuscular blockade. The inhalational anesthetic also depress the muscles, right? It will lead to the aggravation in the muscular depression, right? That's why the anesthetics aren't given with the aminoglycoside, right? And they are effective with the beta lactam, okay, and show this synergistic effect. But one thing is that the aminoglycoside shouldn't be given with the beta lactam in the same syringe, okay, that I told you in the cephalosporin also. Okay, so the same text is going, okay, you can fit the same text everywhere, right? And we'll be discussing about the chloramphenicol, macrolides, okay, and lincosamide. You'll see that they are one contraindication is that you shouldn't be using that three class of the drug together, because they have same side of action, right? So you can just cut, copy, and paste the previous text here also, right? That's why I had told you just study smartly rather than just mugging it up, right? Okay, so you can see over here also that there is a drug interaction between the beta lactam, right? So you shouldn't be giving the aminoglycoside along with the beta lactam in the same syringe, right? I hope this part is clear. Okay, and the cephalosporin along with aminoglycoside show the additive nephrotoxic effect, right? And the higher concentration of carbonicillin, ticarcillin, and piperacillin may be going to inactivate your aminoglycoside. Okay, done. And not to be given with the diuretics that I had told you earlier also, with the furosemide and mannitol, which are the diuretics. You should not prescribe the aminoglycoside along with them, right? So this was all about the aminoglycosides. So thank you everyone, this was from my part. Okay, thank you.